And before we begin the advanced analytics panel, I want to invite Regina Holliday to the front of the room. Regina is an artist and patient advocate and speaker and just a real champion for patients' rights in the healthcare space, and has been leading a number of efforts in helping bring about sort of a patient-centric health system through her art, and has really touched a lot of people and a lot of lives. And we've had her here with the workshop in Health IT and Economics for 3 years now. And one of the things that we really enjoy, we find the audience enjoys, is to have Regina sort of paint her interpretations of the talks during the day and then share that with the audience. So with that, I'm going to ask Regina to give us a few remarks on your painting.
Thank you so much. I'm so glad to be here again. This time I drove here because I live out in the country up in Western Maryland, so it took 4 hours to get to you. I left at 5 o'clock this morning, and I was super excited to see you all and to paint about, once again, the wonderful studies that you have done in the past year. And so this painting right here is called Thought Process, because what I was hearing is this wonderful evolution of what happens. So within this infinity swirl, because don't assume this is just two swirls on a canvas. This is the part we captured today. It keeps going and going and going, because we are constantly changing and improving what we create. So the very beginning of this swirl, we have someone crawling out with a question. That leads to studies. So we have a research scientist with little percentages, and then a congressman with a bill representing high-tech legislation, and then a vendor with a symbol for money. You know, which system are you going to purchase? And then we have another research scientist looking again and inputting data into their computer system. And finally, we have a student asking a question. And it just goes on, right? And what you are doing is constantly making this world a better place. So I applaud you, and I respect you, and keep it up, because what you do changes things for all of us. So that was the conference painting for today, but that is not the only painting I did. Kenyon came up to me and said, could I join the walking gallery? And I said yes. So he gave me his jacket, and we painted his story today. So if you look at this painting, it's called Healing This Wound. And we have Kenyon right here in the center with his family. And we have all the students represented in this room with the wonderful things he's done to inspire you. And he's standing upon a globe where money is beneath him, because that's a business, right? That's a symbol for business, right? But then, looping off of that, we have genomics and data and all of it coming together. And then on each side, he has his stepfather and his father. And his father had MS, and that was a challenging health journey. And you wonder how much his life could be improved if we truly had interoperable systems. And the other side is his stepfather, and there's a wound on his arm. You see, he went to the hospital with a wound that would not heal. That's a data point. But in the old systems, you know, data points aren't tracked, and they're definitely not put together. And nobody put together the picture that Kenyon's stepfather had cancer, and that's why his wound wouldn't heal. And he died, because we have data points that are not together. So you know what we're doing in this room? We are healing this wound. Thank you.
Thank you. Yeah, it's actually true. It's kind of emotional seeing that on a jacket. So go ahead, go on my back. So no, it's true. But and you know, as we look to, especially in preventive care with Mac, who was a small business owner, and with so the wound on his arm, it's ended up dying from colon cancer. But colon cancer is one of those preventive diseases that if you follow the recommended procedures, if you're seeing your primary care physician, if you have access, you're doing that, then it's one of those diseases that can be prevented in almost all of the cases, majority of the cases. And so, I mean, it is one of those things that sparks me on to help people sort of understand their health information and the opportunities to engage with preventive medicine and have healthy behaviors. So thanks again, Regina, for that. So at this point, let's turn it over to our advanced analytics panel, one of the sort of hottest of hot topics in the health industry right now.
Hello.
Let me turn it over to Professor Zhang.
Thank you. Good afternoon. Thanks for attending this panel on advanced analytics in care delivery. I'm Dongsong Zhang from University of Maryland, Baltimore County. This panel is about how to use data analytics to improve healthcare. We are fortunate to have 6 panelists in this panel to introduce their work in this area. First, please allow me to introduce our panelists. The first panelist is Yi-Ye Zhang from Carnegie Mellon. Here. Yeah. Ralph Gross from also affiliated with Carnegie Mellon. And Joyce Byrne from MITRE. Yakovos Kassipis from University of Maryland. Gunesh Karu from University of Maryland, Baltimore County, sitting far from me. And Xiao Liu, I believe, sitting in the audience, also from Carnegie Mellon. Okay, so here's the plan. We will have each panelist to take about 5 minutes to introduce their work, and then at the end, we will open the floor to the audience for questions. Okay, so without further ado, let's welcome the first panelist, Yi-Ye Zhang from Carnegie Mellon.
Thank you. I just couldn't wait, so I stood up. Okay. So this work is jointly done with Dr. Rema Panman, also from Carnegie Mellon, and the goal of this paper is to learn and visualize the data-driven clinical pathways from the electronic health records data. And so I first wanted to talk about what we think, what we mean by clinical pathways. So clinical pathways is a map of clinical visits that patients go through during their treatments. And we're specifically looking at patients with chronic conditions, and these patients are treated in an outpatient setting, and they repeat visits to the hospital, to the clinician's office over time for a long period of time. So, so the interesting questions in looking at these patients is to learn the common pathways that these patients take in their treatments, and also how are these pathways different from one patient group to the other, and then how can we use such information to improve the care of healthcare. So actually one challenging question, and surprisingly challenging question, was how to represent this data. So if you work with patients with chronic conditions, you probably know that all of these patients, they suffer from multiple conditions. So every time they come to see the doctor, they get multiple diagnoses, they receive multiple medications, they go through multiple procedures and receive multiple medical orders. And if I were to apply traditional process mining or workflow mining methods on these, I'll be getting things like the prescription of diuretics led to the prescription of antihypertensive medication, and that prescription led to the diagnosis of hypertension, and then the diagnosis of diabetes or so on. And that's not the kind of relationship that's happening. So rather, we develop some novel constructs to represent a pathway of temporal relationships that shows that the patient comes in to see the doctor with hypertension, with diabetes, and receive diuretics, antihypertensive medications, and so on. And by representing all these multidimensional and longitudinal data in a pathway form or sequential form, we're able to calculate the similarity of these pathways by using, for example, measure like longest common subsequence, and then using such similarity distance matrix to apply some clustering algorithms to find the latent patient subgroups that's in the data. And within each patient subgroups, we can visualize and model these clinical pathways as Markov chains, and really find the interesting pathways that the hospital management may be used to improve the care quality. So this is a clinical pathway example. The circles here represent a visit of a specific type. So one visit may be a hospitalization where patients are suffering from some acute conditions and received multiple medications. And the edges represent, so the thickness of the edges represent the transitional probability or the transitional frequency. And if you drill down deeper into the clinical pathway, you'll find interesting pathways such as, so typically patients with chronic kidney problems, their kidney tend to just fail and do not improve. But here we found that for some patients, their kidney functions actually improved a bit. And for these patients, a lot of them actually went to education classes and learn about their conditions. So it is possible that learning more about their conditions can help patients improve their conditions. And so the next step, which is also what I'm working on right now, is to take these data-driven clinical pathways to predict the future care. So the interesting question will be when a patient comes to see the clinicians, given their demographic information and their clinical histories, what are the potential outcomes of these patients given different treatment plans? And our plan is to use dynamic Bayesian networks to model this complicated treatment process to associate different treatment plans with the potential outcomes so that the physicians and their patients can make more engaged decision-making about the potential treatment options. And for now, we have some fair prediction accuracies. We are able to show that to demonstrate prediction accuracy of 0.63 up to 0.92, so it's a promising work. And I hope to work more deeply into this problem in the coming months. So that's about my time. Thank you.
Good afternoon. My name is Ralph Gross. I'm the chief scientist of a company called Disruptive Robotics. And at Disruptive, we're concerned with building intelligent systems that help practitioners in hospitals in dealing with the logistics of healthcare delivery. Our particular focus is on the boundary between the emergency department and the interior of the hospital. Now, as you probably all know, potentially through your own experience, emergency departments in the US and in other countries around the world are often full, leading to patient wait times. Now, there are a number of reasons for that, part of which is the function of the emergency department within the hospital as a gateway into the hospital. Now, the front doors of the ED are always open, but the back door is often closed because there are no inpatient beds available for patients in the ED. And when that happens, then patients wait in the ED, which leads to bad medical outcomes. The hospitals lose money, and patients don't like it because they have to wait. So now, to illustrate our approach, I show here the, does this work? Yeah. This is sort of a typical trajectory that a patient might go through in an ED. So the patient shows up, they were registered, then they wait, they're triaged, then they wait, eventually they get to a room, then they wait, and treatment starts, they're diagnosed, and at some point the decision might be made that they have to be admitted, about here, which is typically the first time that the rest of the hospital learns about that particular patient. Now, oftentimes there is no inpatient bed available for that patient, and the interior units have then create that bed space, which takes time. Now, in our approach, we build a system that predicts hospital admissions based on triage data. So much earlier than the point later here when the admit decision is made. And so the bed preparation process can happen in parallel to the ED treatment process. We have a mobile device system that Idris is going to talk about tomorrow morning that we use in order to communicate that information to the interior units so that they can start bed preparation process earlier. In order to do that, we build a machine learning system. We use a support vector machine to classify the patient visit data into either a discharge or an admission. And we use this set of features described here: patient age and gender, time of arrival, mode of arrival, as well as their acuity and chief complaint in order to feed that system. And we trained that system on about 4 years worth of data from a community-sized hospital in Western PA. And the system is running right now, and it achieves about an 85% prediction accuracy for discharge or admission, which breaks down in a 47% true positive rate and a 93% true negative rate. And what you see also is highlighted here that we get this prediction result, much earlier in the patient trajectory than you would typically see the admission decision being made. So there's much more time for the interior units to prepare for the patient than they otherwise would have. We've also been able to show that our system reduces the patient length of stay within the ED, the details of which, again, Idris is going to talk about tomorrow morning. Thank you very much.
Hi, my name is Joyce Byrne, and I work for the MITRE Corporation. Myself and my coworkers, Brendan Smith and Aman Osman, performed this preliminary research on telemedicine in humanitarian aid and disaster relief. What motivated us to do this research? We've experienced a number of disasters personally, Sandy, Katrina, Joaquin. So we started looking at UN reports. And if you look at the chart on the screen, you can see that the UN report says that over the last decade, natural disasters has increased. And the report goes on to say that it's having an increasing impact on people, infrastructure, and economies. It also predicts that this trend is going to continue. So what we did for our research is we looked at after-action reports. So after every disaster, they do after-action reports or lessons learned on what went wrong. And we saw recurrent themes. When a disaster occurs, there's frequently mass confusion. You don't know where people are, you don't know if they're in safe situations, you don't know what resources they need. This is what's called situational awareness, and there's a lack of it in disasters. In addition, local authorities are in charge, but again, they might be in unsafe situations, they might not have communications, so there's generally a lack of command as well. In the beginning, a lot of agencies show up, local, federal, and state, as well as some international aid organizations. And they frequently bring their own communication devices, and there's a lack of interoperability, so kind of a common theme here, right? And this causes a lack of communication, a lack of coordination, and a lack of collaboration across the event. There's also a high risk of disease and infection in disaster areas. So our question is, what can we do to eliminate this or help improve the efficiencies of the planning and the relief efforts? Our recommendation, whoops, I should have had that slide up, sorry. So our recommendation is to do a systems engineering approach. The military experiences what's called the fog of war. It's very similar to the beginning stages of disaster. There's mass confusion, there's lack of situational awareness, and there's lack of command and control. So we would look at the lessons learned from their implementation to try to mitigate this, and that they implemented systems engineering and what's called C4ISR. We would also look at command and control systems. And the purpose of command and control systems is to collect, correlate, analyze, and disseminate the data to get the right information to the right people at the right time, or provide that much needed situational awareness. It would also help with informed decision making. We would also look at generating a reusable framework, and this framework would help inform the policy and planning for disaster relief, and it would ensure that lessons learned are fed back into the system so that it would continuously be improved. We recommend that we would use push packages and telemedicine. And why do we recommend telemedicine? So again, in disaster areas, there's frequently a lack of medical resources, and using telemedicine would help eliminate that lack of resources. It would also provide some of that data that would feed into the situational awareness. It would also, for instance, in the Ebola crisis, there was a lot of first aid workers and humanitarian aid workers who were exposed to the disease. If we had sent telemedicine packages to the local workers, we could have helped eliminate some of that exposure. It would also be used to collect data and help inform decision-making about where the best use of medical resources could be applied. I got a little extra time. Thank you.
Good afternoon, ladies and gentlemen. My name is Jakobos Katsipis from University of Maryland and Institute of System Engineering. Today, we will talk about reasoning engine machine that helps the decision making for potential healthcare management systems. And we are using the model-based system engineering approach. Here we visualize a network where every agent here are the agents that we have in the healthcare, the laboratorians, the doctors, the patients. So every leakage, every person actually communicates each other, and every node produce measurable results. And all these measurable results produce a kind of knowledge that will be stored for the decision making. The potential model can be expandable to other diseases. In the same time, could be also scalable to from a community base up to a state base, like we have the health information exchange systems. We have here two matrices. But we can have many more actually. Here we have a health quality metrics that where V stands for risk adjustment metric that is connected with every patient. So every patient is giving a value for each kind of state that he's into his disease, while O stands for a counting metric where actually we have the result of a patient falling into the specific state of the disease. And the healthcare cost is very straightforward. It's the total cost that we have for all this time period, and we are taking into account all the interventions and all the diagnostic tests that he followed the patients during this period. This is a first result of trade-off analysis that we are doing between two computational methods. The first method is exhausted Monte Carlo method, this stochastic method similar to Monte Carlo Markov chain. And the computing time, you can see that in the right side. And we compare it with FOMCO method, which is a multi-objective method that is using recursive computing, and we are using also dynamic programming. And as you can see, the results are being solved in a fraction of the time. The graphical representations of these computations, you can see them in the left for the EMCS method, for the exhausted method, and for the FOMCO method is in the right bottom side. For the simulation, we use 10,000 simulated patients, and we had 32 iterations, and every time the mechanism had to choose based on what kind of outcome we were receiving, what kind of iteration or test he will use. And for this test, we had 3 interventions, 3 diagnostic tests, and 10 interventions. Other examples of trade-offs that we can have here, as you can see, is 2 tables where the V vector is translating now as a type of patients, and we track actually every improvement from a 3-state disease. And we can see from every transition, any improvement, what kind of test and what kind of intervention we were using. And among all the cases that we had out of these 10,000 patients for these 10 years, we see how many times this intervention shows up and how many times this intervention is related with this improvement, where improvement is getting from a more disease situation to a healthier one. And in the last column, we have efficiency factor, which is actually related with the intervention that has been used and the improvement that has been having. And of course, you can include inside much more metrics like reliability of disease or for the diagnostic test that you're doing, or maybe you can use and other quality metrics based on what he wants the decision maker. Thank you very much.
Okay, so this is a study by myself and my PhD students, Pooja and Dari, who couldn't be here today. We are from the University of Maryland, Baltimore County. So I'll skip some of the slides. How many of you know about home care? So this is, we have quite a lot of number. So this is provided by home health agencies under a physician's order. So it covers skilled nursing care, physical therapy, occupational therapy, or sometimes even assistance from a home aide. So we are trying to basically understand how we can improve the processes in home health agencies to reduce the hospital admission rates and avoidable ER visit rates for home care patients. However, home health agencies have very limited resources, so they cannot spend a lot of resources for improvement. So how can we do this in a focused and prioritized manner? So that was the basically essential question for this research. So why is it important? We heard about value-based payment this morning. So this is coming to home care as well, starting from January 1st. In 9 states, a value-based payment program will apply, and home health agencies are now under pressure. And frankly, it also creates a depressing environment for many small providers now, because they cannot dedicate a lot of resources for process improvement. So we hope that we could, provide some kind of feedback so that they could get highest return on investment. So we use the Medicare Home Care Compare data with some additional variables, control variables such as rurality, median income, so that we could basically include them in the analysis. So our response variables are hospital admission rate, unplanned ER visit rate, and also 30-day admissions and 30-day ER visits. So the last two were only introduced for the recent year, and it comes from an incomplete data set. So these are the predictors used, and we use a method called tree-based modeling. I'm not going to go into the details of this, but so this is the first model. So interestingly, our control variables appeared at the top of the model. So in a tree-based model, the variable that reduces the variance most will appear at the top. So we see the rurality variable. So the rural agencies here appear on the right-hand side have a higher hospital admission rate. The others have 15.16. So we recursively split the data sets, sub-data sets continuously. And the next variable appeared to be agency size. So larger agencies, because possibly because of some coordination issues, have higher hospital admission rates. And then we have some process variables. The first one which appeared was checking for fall risks. So whether the home care nurse checked for fall risk or not, whether the care started in a timely manner, that came as the next variable. When we look at the ER visit rates, again, the rurality appeared at top, and then we see checking for fall risks, starting care in a timely manner, treating patients for pain, and also agency size appeared in the model. For the 30-day hospital readmissions, so this is basically where the response variable is a categorical variable, and we have, again, agency size and checking for fall risks appearing in this one. For the 30-day ER visit rate, we obtained a tree which was only root, so there was no variance reduction by picking any of the variables. So as a discussion, we can say that these non-clinical variables are very crucial, so we need to include them in analysis. And if we want to give any advice to home health agencies about which processes they need to focus on first, it is the checking for fall risks and also starting care timely. These are very, very important. And for urban HHAs, also treating patients for pain reduce the ER visit rates. As visit count increases, possibly collaboration and coordination is becoming more difficult. And why do we have higher rates for rural agencies? We can just hypothesize maybe quality improvement is difficult for those agencies. They could be small. Maybe patients are less healthy to start with. Maybe there are health literacy levels, lower health literacy levels, or they have less access to primary and secondary care. So whenever there's a problem, they may be just going to the hospital or the emergency room. So these are the main results. Thank you very much.
Hi everyone, my name is Xiao. I'm a PhD student in University of Arizona. Today I'm going to present a research progress with faculties in our university and co-workers from Michigan State University and Carnegie Mellon University. So the topic today is about visual social media analytics for patient-centered care. So the motivation of the study is we observed that chronic disease is among the most common and costly of all the healthcare problems in the United States. According to a study in 2012, about 170 million people are diagnosed for chronic disease, and treating those patients actually costs about 84% of the all healthcare spending in that year. So due to this large amount of cost for treating chronic disease, self-care is an important component for chronic disease management. Thinking about education patients with medical knowledge to improve self-care, and it will ultimately enhance chronic disease management. So in recent years, social media has emerged as an effective approach for self-care education. Video sharing websites such as YouTube have been proven as an effective platform for sharing medical knowledge. And self-care ability can be improved when patients actually go to YouTube and watch videos containing proper patient education and knowledge about how to maintain their conditions and promote their health. However, searching videos matching patients' information needs on social media platform is still a challenging task for patients. There are multiple reasons to this situation. First is the search function for YouTube. This platform only matches the keyword for video titles and the tags of the video created by the content uploader. The second reason is patients sometimes may not have the correct and precise knowledge about what they should use as search keyword. The third situation is the video titles and tags are assigned by the content creators. Sometimes they describe the video inaccurately and provide misleading information just to attract attention. So there is a screenshot of search results that we type in the YouTube interface for search for information about cure for diabetes. And the picture shows the top 5 search results, and we can see that the first search result is strongly biased opinion towards seeing doctors for diabetes. The second video and the fourth video are commercials for diabetes treatment, and the third video is a talk given by a medical expert sharing his experience for managing the disease. And the fifth video is containing false information about curing diabetes in 72 hours. So based on this observation, we feel it's very critical for health video search system to provide patients with easy access to video contain helpful medical knowledge and to avoid false health information in order to improve the self-care education. To address this issue, we propose to develop a deep learning-based knowledge extraction system to address this problem. First, we look into the literature for what kind of medical knowledge that matters for patient self-care. And we find patients often look for treatment, disease, and symptoms when they search, when they look for information on the internet. And then we think about how can we approach this problem as identify relations between treatment, disease, and symptoms. So we try to model it as a relation extraction, which look for semantic relations between medical terms such as drug names, disease name, and symptoms. So we develop a recurrent neural network model to address this issue. So extract the semantic relationship in the text is naturally a difficult problem. We compared our model with the supervised machine learning model with support vector machine, and our model actually achieved a better performance. So we just finished the pilot study on collected data and conducted the relation extraction on a small data set of about 5,000 YouTube video results. And in the future, we are trying to go beyond just extraction. We are trying to combine the medical knowledge from the social media, what kind of relations expressed by user-generated content with what knowledge exists in the medical knowledge basis to see the quality of the videos on YouTube related to healthcare topics. And we also try to design a user study to evaluate how patient video search experience can be improved by filtering these false information, and how can this improve the patient education. And that's all.
So my question is to Rolf. What was the door to doc time in your sample?
So in that particular hospital, they don't use physician in triage.
Sorry?
They don't use physician in triage. So
Yeah,
the
so
times
first
are
provider
longer.
contact was...
It's about half an hour.
Okay. So I was wondering if perhaps you're doing it, you're using prediction based on triage data, but after physician contact, they may enter some CPT codes, and then lab tests will start coming in. Do you actually improve your prediction as the patient is going through that the ER? Or at this point, it's just triage data and you predict, and then that's all?
So in current operation, we only use triage. That is mostly due to data access issues. So we recently got access to the EMR components that give us additional information as it's collected during the patient visit. And we're in the process of including that as well. Right. Yeah, and we certainly wouldn't argue that you're ever going to build a system that's 100% accurate just on triage data. So it's doing a good job in cases that are not difficult to figure out. If somebody shows up with abdominal pain, these are oftentimes hard to figure out because there are a number of reasons that might cause this. And so the point really is not so much in the accuracy, but it's more in the overall system setup that allows our system to run in parallel to the regular processes, and alert the interior nurses to likely candidates that they might see. So in order for the system to be helpful, it doesn't have to be 100% accurate. It has to just be accurate enough to provide the value that we're looking for.
So is your ultimate goal to replace anyone in the triage?
No. We wouldn't suggest that. We have too many physician investors to do that. We're not trying to replace the human component in here, but what we're trying to do is offload them from these logistics tasks that nobody wants to do, that people aren't particularly good at, because you've probably been in emergency departments. It's a very chaotic environment. people are interrupted all the time, and it's hard to do these sort of mundane things of keeping track of, like, here's the patient, here's what I have done, here's what needs to be done, here's who I have to call, here's who I have to notify, and for these kind of tasks, a intelligent system is much better suited. It's not to assess a patient and come up with the best treatment.
So I would like to thank the panel, for presenting such cool technologies, right? So the next step is about how to make these tools being used by the providers. So my question is to everyone here. I wonder whether you could share some insights on how to create the buy-in from the provider side. That is, they are interested in using the tools, and this really creates some meaningful impact.
And I can start here. So I shut up after that.
Question's too hard.
So our system is currently in use in a hospital, and we're in the process of rolling it out into other hospitals as well. And generally, the feedback from the providers has been very positive. So they're interested in the technology, they see the value, and they are more frustrated about the challenges that exist in order to fully deploy it due to us needing data out of the EMR. It's typically a situation where we talk to the physicians, we talk to the administrators, we talk to the nurses. They all say, "Oh, that's great, let's do it," and then it takes 3 months in order to get data out of the EMR. And it's something that they encounter many times throughout their day. So that's really the biggest hurdle we face.
So usually the issues are when you ask the provider to change their behavior somehow, then there is pushback. Have you actually asked the nurses to add some additional information so that you can use it in your system?
It's true, yeah. Whenever people have to change, there's resistance against it. So we try to address it by not just showing up and saying, "Hey, here's our system, use it," but in trying to incorporate their feedback into how they want to use it, how the interface should be designed. We do run into issues occasionally where the providers are older, they're not very technology savvy, they don't have a cell phone. So, part of our system, as Idris will talk about tomorrow, is mobile based. So they use iOS devices, and if you're a 60-year-old person that doesn't have a smartphone, doesn't want to use a smartphone, then that's a certain barrier. But I'm sure that problem will disappear over time simply because the technology is so pervasive. I think I should shut up and give other people opportunity to speak.
So I think on the provider side, one important thing is the availability of resources. So I think not every provider has time and money to develop predictive algorithms, or even sometimes purchase the IT tools which can make the predictions. But an important aspect of predictive analytics is interpretability of the models. So if we have more open data out there, if the research is reproducible, we can actually provide the providers with some packaged recommendations so that they can improve the quality of their services. So it's a little bit indirect benefit. So they don't have to sit in front of a computer, run a program, and then do blindly. Probably they wouldn't even trust directly the results of the predictive algorithms. So they need to see why it's working, how it's functioning.
Just follow on. This is a very good question. As researchers, we hope eventually the technologies we developed can be useful and can really improve the healthcare service. In reality, there could be many barriers to prevent healthcare providers to adopt our technology. My personal experience, many years ago, I went to a hospital and talked to the person who was in charge of the IT in the entire hospital. So I talked about mobile health systems, the sensor-based systems, what they can offer. And the person said, this is great, but we cannot use it. So why? Because, the healthcare is somehow very sensitive, very critical domain that allows very, very minimum error. So this person says, if your system generates a wrong recommendation, for example, you attach the sensors to this patient to monitor or predict when this person may have a heart attack, right? And your system detects, well, there's a very high chance, in 15 minutes or so, this person will have a heart attack. Then you send an ambulance to this person's house, then he may get, frustrated, right? So a lot of things, and also another feeling I have from my experience, interaction experience with doctors is still, as researchers, we probably IT researchers, for example, we need to also educate those healthcare professionals in terms of what today's technologies can offer. Because in many cases, they may not be aware of, the current technology. Okay.
Hi, Raymond Dewey from the National Library of Medicine. This is for Joyce in the telemedicine research or topic. Telemedicine in post-disaster situations is not new. There has been a lot of papers on it. And from your presentation, the information is a little vague. What do you mean by telemedicine packages? In post-disaster situations, if you send in, the situation is there might not be a lot of healthcare professionals around the area that are trained to operate whatever package you send them. Presupposing telemedicine intervention, you have to have a HIT framework or system that will operate with it. So what particular detail was in your presentation? It was just a little vague. Thanks.
Well, obviously the telemedicine needs an infrastructure, it needs a communication devices. So that's what the push packages would help bring in that communication device. And yes, the telemedicine, obviously the kits would need to be able to be utilized by folks who are not medical experts. So there is research to be done and ensure that those packages could be easily usable by folks on the ground.